Thank you for joining us for the second of the PSPS surgical webinar series. Tonight we'll be talking about perioperative pain management, and we're going to allow everybody just a moment to get logged in, and then we will begin the program. Again, we are just going to allow everyone a moment to log in, and then we will begin the program. Thank you all for joining us. We are going to allow one more moment for everybody to log in, and then we will begin the program with our moderator, Dr. Eric Lee. Thank you all for joining us. We will now begin the program.
Good evening, everybody. Thank you so much for joining us tonight at the PSPS surgical webinar series on our second lecture about perioperative pain management. The next slide, please. My name is Eric Lee. I'm the current president of the Pacific Spine and Pain Society, and you can see my disclosures here. And basically, this evening, we're going to spend about an hour to an hour and 15 minutes talk about something that, I don't think we spend enough time talking about. And that is what do we do with our pain patients during the perioperative period. Most of the time, many of our patients have had chronic pain issues for a long amount of time, and we've been treating them with various medications, therapies, and interventions. And then they might need some surgical intervention. And during that surgical intervention, we know that there's going to be an increased amount of nociceptive pain caused by the procedure. So how do we balance what we've been doing with the patient? How do we optimize that patient prior to the surgery? How do we care for that patient's pain issues during the procedure and immediate recovery? And then what do we do afterwards in terms of a plan of either weaning down or changing the pain regimen for the patients? And so today our learning objectives are this. We're going to understand some of those risk factors for acute and chronic post-surgical pain. We're going to learn how to mitigate that acute and chronic post-surgical pain. We're going to understand the goals of transitional pain management. We're going to learn about the role of opiates in the perioperative pain management period. And we're going to learn about the role of non-opiate adjuncts to post-operative pain as well. And to help me do this, we have an amazing faculty that you can see here. And, I'll go a little bit of introductions for them. First, we'll have Dr. Jennifer Ha, who I've been honored and lucky enough to meet many years ago in New York, and she's an adjunct professor up at Stanford University, and she'll talk about the role of opiates. Then we'll have Dr. Ian Carroll, who's also at Stanford, and he'll be talking about the perioperative medication management for non-opiate medication use we can use. And then we're very lucky to have Dr. Ravi Prasad, who's the Director of Behavioral Health up at UC Davis, and he'll be talking about non-medication therapies and strategies we can use. And then we'll transition over for transitional pain management to Dr. Timothy Furnish, who's down at UCSD. And then finally, we'll have a special guest, Dr. Stephen Filowski, a spine surgeon, who will be helping us moderate a town hall where we'll have, in addition to the panel members and faculty we've already listed, we'll be joined by Dr. Einar Odestad and Dr. Mohammed Reza Razuli as well. So we're very, very lucky to have this amazing faculty and appreciate your time this evening. And without further ado, Dr. Jennifer Ha.
Thanks very much, Dr. Lee, for that introduction. I'm just going to step right into the next slide here. These are just some of my brief disclosures. I will be talking a little bit about off-label medication use in the presentation today. Let's skip to the next slide. So this is just an echo of the learning objectives. This is going to be really painting a broad swath in terms of the approach to perioperative opioid management. If you do have any questions, feel free to email me. My email is jhah@stanford.edu. Let's go to the next slide. So these days, we really can't talk about opioids without referencing the opioid crisis. So I thought I'd show this slide, which is the latest data coming from the CDC. You'll see that it ends in 2018, and it's going to be really interesting to see how things change with the COVID pandemic. But as of going into 2018, you can see that we are actually seeing a downswing in the overdose death rates related to the commonly prescribed opioids, and it's becoming more and more an issue of the synthetic opioids. Let's go to the next slide. So what are the risks of preoperative opioids? We know that there are some established negative effects for the patients who are taking opioids prior to surgery. Increased mortality, increased healthcare utilization. There's an increased risk of all types of hospital readmissions, whether it's for pain or for other causes, and generally for surgical complications and some evidence of impaired wound healing. Let's go to the next slide. So what about for our patients who exhibit some signs of perioperative opioid misuse? Opioid misuse is interesting. It's a little bit difficult to characterize, especially in the perioperative space, and it's generally defined as any kind of opioid use other than prescribed. But we see a similar story here. If we have patients who are exhibiting some sort of opioid misuse, they're at risk for increased mortality, morbidity, and resource utilization. Let's go to the next slide. So in general, what are our strategies for opioid minimization, or what are our goals? And I think that even though I'm focusing on the opioid management, the one thing I do want to emphasize is for the majority of patients, they're going to stop taking their opioids regardless, long before the pain actually does go to baseline or resolve after the operation. And so, yes, we are really focused on opioids, but I just want to emphasize that the main issue still to this day is optimal perioperative management in the hopes that it will transition to good outcomes and prevention of post-surgical pain. So going back to opioid prescribing, there are different ways that we can minimize opioid use, whether it is influencing clinician behavior, patient factors, or just organizational strategies, which I'll present a few in the upcoming slides. Let's go to the next slide. So just to summarize, we have here our organizational, clinician-mediated, and patient-mediated strategies. And the opioid minimization is good for several reasons. We want to limit the surplus, the general surplus of medications prescribed, because we don't want those to end up in the medicine cabinet and potentially into the wrong hands. So that is one of the easiest strategies, is just to not prescribe an over excess. But that doesn't necessarily address all of our patients, especially the ones who have chronic pain, who may be taking chronic opioids before surgery. Let's go to the next slide. So what is an example of an organizational strategy? So this was a study in pediatric post-tonsillectomy patients with pain. And this was a simple default order set change. And so changing from a default of Tylenol with codeine or Tylenol with hydrocodone to Tylenol or ibuprofen dropped the opioid prescribing from about 82% to 15% after surgery. So a very effective way of just simply not over-prescribing. Let's go to the next slide. Here's an example of clinician-mediated strategies. So in this group, they developed procedure-specific opioid prescribing guidelines for hand surgery. So this was based mostly on historic trends in this particular hospital, and it involved clinician training combined with pocket reminder cards. They also did a little bit of default order set changes in their EHR, and we see that the mean number of opioid tablets prescribed dropped between 15 to 30% based on the type of operation. Let's go to the next slide. And this is just an example of this pocket card. And what I want to emphasize again is on the left, and this is going to be so key because Dr. Carroll is going to be talking about those non-opioid pain management strategies. But you can see here that the recommendations include the nerve blocks, the use of Precedex, ibuprofen, Tylenol, cryotherapy. So even though we are minimizing opioids, we want to make sure that we are maximizing all other options for pain control. And then we can see based on the operation type that there is a variable number of pills prescribed. Let's go to the next slide. So what is a patient-mediated strategy? A lot of the ones that have been described involve patient education. And so this is an example from the Pennsylvania Orthopedic Society. They have a protocol where they educate patients about the opioid crisis in general, encourage the use of non-opioid medications, and with that alone, those who received counseling did take a significantly lower number of tablets. Now, we could argue that a difference of 3 pills, is this really clinically significant? But we could see here that maybe for operations that do require more opioids, we might see a greater effect. Let's go to the next slide. So in general, there's been a lot of focus on limiting prescribing through changing our behaviors as clinicians or the patient behaviors or organizational strategies. But again, this probably doesn't get at the burning question of the patient that we picture in our mind that we have so much trouble helping. So what about those patients who we expect are going to have atypical pain trajectories? Maybe those coming in with chronic pain, those who are already taking higher doses of chronic opioids, we know that they're going to have increased requirements, and oftentimes those are the very patients that are excluded from these trials or these quality improvement measures. Let's go to the next slide. So here is an example. This was a cluster randomized controlled trial of 235 patients undergoing primary total hip arthroplasty. And so group A was the most conservative group, got the multimodal analgesia, as you can see below. They got a very conservative amount of oxycodone as needed for emergency pain relief and tramadol. And then group B also got multimodals, a little bit more opioids, and group C was a more traditional approach of no multimodals and the 60 tablets of oxycodone. And we see that in group A, there was a significant reduction in the duration of opioid use of about 1 week versus 2.5 weeks, and also a corresponding reduction in pain. So we see that it's possible for the majority of patients. But one important caveat again here was that if patients were using chronic opioids in the 3 months prior to their hip arthroplasty, they were excluded from the study. So we want to be really careful and take what we see as guidelines being developed or studies that we see, that we take it with a grain of salt, or we actually peel back the cover and make sure we understand who were the patients that were being studied. Let's go to the next slide. So I just wanted to take a few minutes and go over our latest research findings. So we've developed a motivational interviewing based guided opioid tapering support intervention, and we studied this in a pilot randomized trial. Let's go to the next slide. So here is just the meat of the MI opioid taper. So once weekly, we made a recommendation, usually to decrease the dose by 25%. We can go back to the previous slide for 1 second. And we monitored opioid withdrawal symptoms as well as pain severity scores. And all of this was administered through a motivational interviewing framework where we provided support and advice. And really, we didn't change anything with the opioid prescribing. This was just actual patient consumption, patient-reported opioid consumption that we were tracking. And we followed these patients for a year out, making sure we track their pain, the recovery after surgery, as well as opioid cessation. So we were really trying to make sure that if we're encouraging opioid cessation, that we're not causing negative outcomes later on down the road. Let's go to the next slide. So we had about 50 participants per group. We can go, yep. So here we have our main outcomes. So we see that we had a significantly faster return to baseline opioid use. So if you're a chronic opioid consumption person prior to your operation, it was a faster return to your baseline dose. And we also saw that there was also a significant time, reduced time to opioid cessation with our intervention. So all positive things. We didn't negatively affect pain. We didn't increase the time to recovery. And so we see here that simply calling patients and providing advice on average about 2.5 times for the duration of our study had these significant effects. Let's go to the next slide. And here we can see in our survival analysis, this was the graph. The group in blue is our usual care group, and the group in red is our MI opioid taper group. And you can see that significantly faster return to the baseline opioid dose there. Let's go to the next slide. And this is the time to return to complete opioid cessation. And you can see in the group that did not have any type of opioid tapering support that there are still some folks who are continuing on even a year out on their opioids. Let's go to the next slide. So no talk about perioperative opioids would be complete at this point without talking about opioid replacement therapy for opioid use disorder. And one of those medications, as we all know, is buprenorphine, usually combined with naloxone. And just as a reminder, 1 milligram of IV buprenorphine is about 75 milligrams of oral morphine. 1 milligram of sublingual buprenorphine is about 10 milligrams of oral morphine. And so there's basically two strategies, two camps, whether we should continue the medication through the perioperative period to minimize the chance of a relapse risk, or taper patients off of their dose prior to surgery, or some in between. Let's go to the next slide. So this is one example, was to discontinue the buprenorphine about 3 days before surgery. And the problem with this approach is, again, the serious risk of relapse and overdose with transitions in care. Once a patient leaves the hospital and is taking a full opioid agonist, how long is it going to take for them to be able to transition back to their buprenorphine through office-based induction or otherwise? Let's go to the next slide. So the alternative is to try to continue the buprenorphine throughout the perioperative period. A few reminders: sometimes the buprenorphine is dosed once daily or even less frequently, so we can try to piece that dosing interval down to 6 to 8 hours to improve the analgesic benefit. We're going to expect that we're going to need to use more short-acting opioids in the form of maybe fentanyl or other agonists in the form of a PCA. Definitely want to rely heavily on our multimodal analgesia. And we've seen through protocols that this can work. And if patients are taking high doses of buprenorphine, maybe 24 milligrams daily, that having them taper, if you have time, down to a dose of say 16 milligrams will open up the receptors just a little bit to allow for this strategy to work. And the nice thing with this is that the buprenorphine is maintained throughout the perioperative period, so that transition is going to be a lot easier. Let's go to the next slide. Another opioid replacement therapy we have is Naltrexone. This is a pure opioid antagonist, and it's FDA approved for the treatment of both opioid and alcohol use disorder. The oral formulation has had poor uptake, and very few patients are able to maintain on that. So you're more likely to run into someone who's got a monthly depot injection of this medication. So obviously, if we have time, we want to delay that elective surgery for 30 days, and we're going to see that it could be an issue, for example, if someone comes in as a trauma. Let's go to the next slide. And our final OUD replacement therapy category is methadone. It's usually dosed daily. So again, a good reminder is to parse out the methadone dosing to 2 to 3 times a day. A very tricky pharmacology here, whether you've had apple juice or orange juice, that's going to change the excretion of the methadone. But generally, because it is a full-on opioid agonist, we want to continue that throughout the perioperative period, but I also expect that they're going to need more opioids on top of it. Let's go to the next slide. So coordination with the prescribing provider is going to be key for optimizing the outcomes. We want to make sure that there is going to be an appropriate handoff and that that person is going to know what the plan is for a combination of opioid agonists and opioid replacement therapy or otherwise. And it seems like every day there's going to be a new formulation out for buprenorphine that's not necessarily for OUD treatment, but maybe for acute pain. So keeping track of all of those formulations and knowing that they're not all dose equivalent is going to be important as well. Let's go to the next slide. So definitely I want to emphasize care coordination. There's a lot of strategies to limit opioid prescribing. What we definitely don't want to forget are high-risk patients, that they may not necessarily be able to reach those expectations, and that there are strategies, simple strategies in terms of providing some gradual tapering support can be very effective for meeting the needs of those patients as well. And now I'm going to hand it over to my colleague, Dr. Carroll, who's going to talk about all those wonderful non-opioid medication options.
Thank you. Thank you for having me. I thought that was a great talk, Dr. Ha. Very impressive, especially the motivational interviewing data that you presented. Basically, talking to patients about their opioids and their desires and expectations to come off of opioids, resulting in not only people coming off of them faster, but a lower percentage of people going on to chronic, ongoing, indefinite opioid use. So I think very important stuff. I'm going to talk to you about the non-opioid ways of addressing acute post-surgical pain. Next slide, please. No disclosures from me. As a result of participating in this, my hope is that you'll consider the non-opioid adjuvants that not only help with the early post-op pain intensity, but may, at least there's some data suggest, may reduce the likelihood that these patients are going to wind up with persistent post-surgical pain, pain that doesn't go away and has them requiring the expertise of a pain management physician over the long term. Next slide. I think there's really three things that I would talk about in this regard. Number one is giving a gabapentinoid. Next slide. As you're aware, the gabapentinoids come in two flavors. There's gabapentin, which is older, it's cheap, it's absorbed in the duodenum only. So the gabapentin is a little bit tricky. There's a amino acid transporter that's only expressed in the duodenum that will pick up the gabapentin because it's shaped like an amino acid and transport it into the lumen. Because that's an active transport process, there is only so much gabapentin you can absorb per unit time, and therefore there's a built-in safety mechanism. You can't get blood levels too high if your renal function is intact, because you simply can't absorb enough gabapentin for it to be toxic. If you try to overdose on your bottle of gabapentin, you basically have most of it flow past the duodenum where it can't be absorbed fast enough. It becomes an osmotic laxative, and you wake up embarrassed the next day with diarrhea. On the other hand, we have this other gabapentinoid, which binds to the same calcium channel in the same place. Pregabalin, it is a little newer, it's just a little less cheap, and it's absorbed throughout the intestines, so that unlike the gabapentin, whereas you take progressively more, you absorb fractionally less. As you take more and more pregabalin, your blood levels go up proportionately, and you don't have that same rate-limiting step of absorption. And so either one of these can be used perioperatively if you have a duodenum. Note that if you have had some kind of gastric bypass where you're no longer having the luminal contents flow past the duodenum, only pregabalin is going to be helpful. Next slide. Let's see the next slide. There you go. So these are the mechanisms of gabapentinoids. What you see here is that we have two real mechanisms that appear to have been elucidated. Both of them are occurring in the dorsal horn of the spinal cord. In the blow up here, what you see is that on the presynaptic primary afferent neuron, as the action potential makes it towards the synaptic bulb, that action potential, which is propagated by voltage-gated sodium channels, reaches the synaptic bulb where it is supposed to activate voltage-gated PQ-type calcium channels. And those calcium channels then open up in response to the depolarization, allowing calcium flux in, which allows the synaptic vesicles full of excitatory amino acids and nociceptive peptidergic neurotransmitters to fuse with the presynaptic membrane, a process that's mediated by calcium influx. The gabapentinoids alter that. They modulate the calcium influx by binding to this alpha-2 delta subunit of these calcium channels, and as a result, you have less excitatory amino acids flowing across that first synapse where the primary afferent neuron is supposed to be propagating that signal to the second neuron and sending it up the spinal thalamic tract. In addition, there's good data that the gabapentinoids enhance descending inhibitory signals that go from the locus ceruleus and are primarily noradrenergic and flow down to that very same synapse and normally act to result in hyperpolarization of both the presynaptic and postsynaptic membrane, making it harder for that presynaptic neuron to activate the postsynaptic neuron. So the gabapentinoids, gabapentin and Lyrica, pregabalin, are both acting primarily at calcium channels at that synapse and also enhancing descending inhibitory signals. Next slide. One of the studies I wanted to highlight is by Bhuvanandran and colleagues that looked at patients undergoing total knee replacement. And what they did is they took 240 patients who were undergoing total knee replacement and randomized them to pregabalin 150 milligrams twice a day for 14 days. And what you see is they had excellent follow-up with 113 and 115 out of the 120 respectively included in their primary endpoint intent to treat analysis. And I'll show you what the data was in the next slide. What they basically found is if you were given pregabalin as opposed to placebo, and they came and they found and they asked you about the incidence of pain either 3 months or 6 months later, what you see is that if you got the pregabalin, the incidence of chronic neuropathic pain in the knee 3 months out and 6 months out was virtually abolished by the perioperative use of the pregabalin, which suggests that not only is the pregabalin useful for early post-op pain, but it's useful for persistent post-surgical pain. At this point, there have been more than 100 randomized controlled trials looking at early post-op pain severity, suggesting that gabapentin reduces early post-op pain severity. There have been fewer trials of pregabalin, but still a large number, again, suggesting that it reduces early post-op pain severity. And this has become part of our standard treatment process at Stanford. Recently, in the journal Anesthesiology, there was a meta-analysis that went back and looked at the decreases in early post-op pain severity and questioned whether we should be using the gabapentinoids universally as adjuncts, noting that for many people, the mean reduction in pain severity was only around a point. And they then went back and said, well, you know, it's generally accepted that you need a 2 or 3 point reduction for it to be clinically significant. But the truth is, for many of our post-surgical patients, especially the problematic ones, they're often opioid tolerant patients. And you're really looking for something other than opioids to help you get from severe pain scores down to moderate pain scores. And if you can reduce their pain a point or two with gabapentinoids, and you can reduce their pain a point or two with NSAIDs, and you can reduce their pain a point or two with acetaminophen, and you can use IV lidocaine to get their pain down another point. Each of these little adjuncts that only by itself reduces the pain a point, when you add them up, you go from having pain scores of 8 out of 10 to 4 out of 10, 5 out of 10. And so I think there is a meaningful place for the gabapentinoids in the management of post-surgical pain, both acute and, as data suggests, like this, perhaps chronic, reducing the likelihood of having chronic pain. And I think it's both part of a overall multimodal regimen that includes other things that by themselves aren't as powerful as an opioid in someone who's opioid naive, but as part of a group of medications can really get someone from the severe pain range down to the moderate. The other thing to remember is if you say that the average drop in pain score with gabapentin was a point, that represents the mean of a curve where some people are really less responsive and some people are more responsive. And so some people are going to have 2-point drops, 3-point drops. The people who aren't responsive, you may wind up discontinuing the gabapentin, but that doesn't make it less useful for those people who have 2 or 3-point drops. Next slide. The other thing that gabapentin perioperatively may be useful for, or one way in which it may be useful, is in reducing early post-op pain severity. It may be that that is the mechanism for its potential effect for reducing chronic post-surgical pain. This is data much like the survival data that Dr. Ha showed, where we looked at early post-op pain intensity among a cohort of patients who underwent one of 5 different surgeries: hip replacement, knee replacement, mastectomy, lumpectomy, or thoracotomy. And we called these patients every day after they'd had their surgery to measure how long it took for their pain to resolve. And one of the things that you see here is the group in red, the group that had pain scores greater than 3 out of 10 on day 1 post-op. Their pain resolved much more slowly than the black group, where the pain scores were less than 3 on day 1. And not only if your early post-op pain was more severe, not only did your pain take longer to resolve, but the proportion of people 6 months out who still had pain was significantly higher, suggesting that interventions to reduce, or at least raising the hypothesis that interventions that might reduce early post-op pain severity might have potential yield in reducing the percentage of people who have chronic pain and perhaps reducing time to pain resolution for the others. And that may provide some insight into why the early pregabalin and the perioperative pregabalin for the first 14 days resulted in a reduced likelihood of having chronic pain at 3 months and 6 months that I showed you. Go ahead to the next slide, please. So when you look now at the studies that support gabapentinoids for reducing chronic pain, not just acute pain, but chronic pain, you find all of these studies. And if you look for studies that, in fact, did not find evidence for gabapentinoids reducing chronic pain, you have this next list of studies. Next slide. And so there's data on both sides. There's more data supporting that there really is an effect reducing chronic pain. The studies that looked at it that did not find data supporting a role for reducing chronic pain tend to be smaller studies, 40 patients, 60 patients, or studies that use lower dose regimens. And so meta-analyses of these studies have suggested that overall, there is data to support that gabapentin may really reduce the likelihood of developing persistent post-surgical pain. Next slide. So the regimen that we propose and that we advocate is either gabapentin, 1,200 milligrams at least 2 hours before surgery, and then 600 milligrams 3 times a day after surgery. There's data looking at the gabapentin suggesting that if you forget to give it during surgery, the anesthesiologist can put it down an NG tube during the case and get just as much of an effect. The regimen used by buvanandron for pregabalin was 300 milligrams 2 hours before surgery, and again 150 milligrams twice a day for 14 days after surgery. Next slide. Second recommendation would be to use ketamine. Next slide. There's now good data among that most difficult group of patients with chronic post-surgical, that most difficult group of patients who are on chronic opioids, that using ketamine in the perioperative period reduces early post-op pain severity. What I want to bring your attention to is this earlier paper that looked at whether ketamine had a role in preventing chronic pain. This study looked at 100 patients with, and that's fine, you can keep the slide, 100 patients with rectal adenocarcinoma. They were randomized to 5 groups. It was a complicated design, but what's important is that they were able to make the comparison of patients with rectal adenocarcinoma who received ketamine starting at 0.5 milligrams per kilogram load IV before incision compared to placebo. And they looked and compared the rate of having pain 2 weeks post-op, 1 month post-op, and 6 months post-op. And what you see is the percentage of patients with ongoing pain at 2 weeks, 1 month, and 6 months post-op in the placebo group is substantial. With 6 months post-op after a surgery for rectal adenocarcinoma, 25% of patients having ongoing issues with pain. Now, those patients generally don't have severe pain. It's a much smaller group that will report severe pain, maybe 5%, 6%, but still 25% of patients having some degree of ongoing pain. In the group that had ketamine, in contrast, no patients continuing to have pain a month out and 6 months out. And so both because of the early post-op pain severity reductions and because of this preliminary evidence suggesting that it may reduce the likelihood of chronic pain, this is a great adjunct to use, especially in your opioid-tolerant patient who is likely to have some degree of chronic pain already, suggesting that they're more likely to develop a chronic post-surgical pain syndrome. Next slide. And the last thing, and so this is the regimen that I talked about, pre-incision 0.5 milligrams per kilogram. And then the last recommendation would be make it numb. Next slide. So there's data looking at 3 different ways of getting numbness. One is regional anesthesia. One is simply infiltrating ropivacaine around the wound. And there's even data that 20 grams of emla-cream 5 minutes before breast cancer surgery and for 4 days after surgery reduces the likelihood of having chronic pain. So 3 different ways, and I'll show you some of the data with this, suggesting again that if you make the nerves numb in the area that your surgery is affecting, you'll actually reduce the likelihood of developing chronic pain. Go ahead to the next slide. So this paper from 2005, neuropathic pain, early spontaneous afferent activity is the trigger, I think gives us significant insight into some of the peripheral mechanisms that help sustain and create chronic pain when a nerve is injured. Next slide. What they did is they looked in a rat model at the sciatic nerve of rats, and what this is showing you here is an experiment in which they gave rats a chronic constriction nerve injury. Basically, they dissected out the rat's sciatic nerve and they tied a loose ligature around the nerve. This is a good way to get a rat to develop behaviors that look like chronic nerve pain. And on the y-axis here, you have mechanical pain score, which they assessed by basically having the rats walk on this grid where they could poke the rats with little fibers through the grid. And they measured the amount of force in grams that they could poke the rat's paw with before the rat would jerk its paw away, almost like allodynia. And what you see is in the rats that had a chronic constriction nerve injury and no bupivacaine put on their sciatic nerve, which is the white diamonds, you have them at time 0 before the chronic constriction nerve injury versus as time goes on, it takes markedly less force on their paw to get them to jerk their paw away. This is just a marker of the fact that if you tie a ligature around their sciatic nerve, the rat's behavior changes and it looks like they really develop a kind of neuropathic pain syndrome, increased sensitivity, and will jerk their paw away with substantially less force than before you injure them. In contrast, if you do the same injury in the black diamonds, can you go back the slide, please? If you do the same injury with the black diamonds, let's bring up the previous slide. There you go. So with the black diamonds, the same injury, but when you give bupivacaine for the first 3 days around the time of the nerve injury, you put the bupivacaine on the rat's sciatic nerve, you don't get the same changes in acquired mechanical pain sensitivity. So those rats, they change much less from their baseline when you give them the same nerve injury, but you put bupivacaine on the nerve at the time that you're injuring it. And you could say, well, you know, how does this apply to what we're doing surgically? Every time a surgeon cuts, they're cutting cutaneous nerves. And while it's obvious that cutting the sciatic nerve or cutting the major nerves leads to nerve pain, it's clear that cutting these cutaneous nerves in some people results in chronic pain. Some of these patients who have chronic post-surgical pain will in fact get temporary relief when you infiltrate local anesthetic in the skin scar, suggesting that even small nerves when cut can in the right circumstance lead to chronic pain. And this data in rats suggests that that can be partially abrogated by putting local anesthetic on the nerves that are being injured at the time of the injury. Go ahead to the next slide now. So they went further in their data, and what they did is they looked and measured the spontaneous firing rate in the C fibers. So the C fibers in the sciatic nerve are among that group of fibers that are primarily responsible for generating nociception and pain sensation. And because they are normally pain-carrying nerves, they normally don't fire spontaneously very much. That's a property of pain-carrying nerves. Normally, in their normal state, they're quiescent. They don't have a normal tonal firing rate. And what you see is, first of all, if you don't injure, on the left-hand side of the graph, if you don't injure the sciatic nerve and you measure the C fibers, you see very low rates of spontaneous activity. On the right-hand side, what you see with the CCI, which is the chronic constriction injury, is if you tie a ligature around the sciatic nerve and you don't do anything else to it, those C fibers they change phenotype and they acquire a new spontaneous activity. So they start behaving like the pacemaker cells in your heart. They're just firing, boom, 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 boom. And those are nerves that are normally designed to be pain-carrying nerves. And so if they acquire new spontaneous activity, that's a good bet that they're going to drive new spontaneous neuropathic pain. What you see in the second bar over, like on the CCI graph there, is that if they had bupivacaine put around the sciatic nerve at the time of the injury, not only do you have less pain behavior in terms of the foot withdrawal of that rat, but the spontaneous activity in the C fibers is in fact still low like it was at baseline. They don't acquire the new spontaneous firing in their C fibers. So the bupivacaine not only prevents the acquisition of the spontaneous activity in the C fibers, but it also reduces the acquisition of that early Paul withdrawal that looks like the equivalent of allodynia. So they have the behavior that's not changed, they have the behavior suggesting neuropathic pain that is acquired to a lower degree when you make the nerve numb, and the neural activity that normally changes with the chronic constriction nerve injury that doesn't change in the same way when that nerve is made to be numb by the bupivacaine at the time of injury. Next slide. And this is the corollary in people. So this is data from a randomized controlled trial of paravertebral block for breast cancer surgery, where they randomized 60 people to either get a paravertebral block or to get a sham block. And what they're looking at over time is the prevalence of pain greater than a 3 out of 10 over time. And what you see is, not surprisingly, if you got a paravertebral block, your early pain right after surgery, if you look 2 days after surgery, the percentage of people who had pain greater than 3 out of 10, very low in the block group. What is surprising is that those differences persist 5 days out, 7 days out, 14 days out. And if you look a month out, 6 months out, 12 months out, the group that had a paravertebral block, i.e. where the nerves were made numb before the cutting began, the likelihood of having persistent post-surgical pain is markedly less. And this data, the rates of chronic post-surgical pain found in this study are very consistent with other studies of chronic pain after breast cancer surgery. So people undergoing mastectomy have, when you look 3 years out, have a 30% chance of having some degree of residual pain, a 13% chance of reporting that pain as moderate to severe. And you see that putting the local anesthetic on the nerves that innervate that area before surgery appears to reduce that acquisition of chronic pain in the same way that would be suggested by the animal data I presented earlier. Next slide. You see similar data here in a randomized controlled trial of people who received epidural local anesthetic for thoracotomy. And what you see here is the 79 patients were randomized to either get a PCA or an epidural that wasn't dosed until after the surgery, or an epidural that was dosed before the incision. And the rates of of having pain at 2 months and 6 months after surgery. And what you see is that the group that got an epidural that was dosed before the incision did the best of the 3 groups, with statistically significant improvements when compared to IV PCA. And the group that got the epidural but had it dosed only at the end of surgery, after the cutting and the retractors were put in and the nerves in between the ribs were damaged, they do maybe a little better than the PCA and not quite as good as those that had the epidural put in and dosed with local anesthetic before the cutting began. Again, consistent with the animal data I showed you earlier, suggesting we should be making patients numb in the place where we're going to cut on them before we do it. Next slide. The references and the papers for the studies I've shown should be available to you through this QR code in a Google Drive that I've shared. And I hope you find it informative and thought-provoking. And thank you very much.
Right. Good evening, and thank you for joining us here. You can go ahead and advance it to the next slide. So I have just that one disclosure. You can go ahead and move on to the next slide. A couple of learning objectives for tonight. In this section, want to have you identify at least one psychological variable that can influence post-surgical pain and outcomes, and differentiate between cognitive behavioral therapy and relaxation training. We can go ahead and go on to the next slide. So I'm going to begin this section by discussing what we've learned from the literature on pre-surgical psychological screening as it applies to surgical outcomes. I'm going to focus on a systematic review that specifically looked at pre-surgical psychological screening as it applied to lumbar surgery and spinal cord stimulation. So the authors of this particular study identified or defined successful outcomes as decreased pain, increased function, return to work, and reduced medical treatment. And I think all of us, myself, my fellow panelists, the people in the audience, I think would all define successful treatment outcomes in the same way. That's certainly what we want for all of our patients, whether we're looking at surgical interventions, injection therapies, pharmacologic interventions, or behavioral interventions. What the authors found is that the authors found that there was a positive relationship between one or more psychological factors and poor treatment outcomes in over 90% of the studies that they reviewed. The most useful predictors of poor outcome were pre-surgical somatization, which is basically physical manifestations of psychological stress, depression, anxiety, poor coping, but the factors that were minimally predictive of outcomes or successful outcomes were pre-treatment physical findings, activity interference, and pre-surgical pain intensity. Now, what I find interesting about this is when I've given, if we could stay on that same slide, what I find interesting about this is when I've given this, reviewed this slide with colleagues, neurosurgical colleagues in the past, when I talk to them about the factors that help them determine whether or not somebody's a surgical candidate, oftentimes it's these lower 3 things. In addition to imaging studies, it's pre-treatment physical findings, activity interference, and the pre-surgical pain intensity. When the reality is that these variables aren't really very helpful in defining who's going to have improvements in their pain, who's going to have improvements in functioning, return to work, and have decreased medical utilization. The reality is that the psychological variables, the pre-surgical somatization, depression, anxiety, and poor coping are more useful predictors. But what's nice is that all of these variables, these 4 variables up here, are modifiable. We can actually reduce the impact that these variables have on patients' well-being to improve their outcomes. And the way that we do that is through psychological intervention. So we can go ahead and go on to the next slide. So there's a plethora of evidence-based psychological interventions that can be used to accomplish this, but I'm going to focus on the ones that are most commonly studied and applied, which are cognitive behavioral therapies and relaxation training. Even though these are familiar to many people, most non-psychologists have a limited understanding of what exactly happens when we work with patients in these areas. So I hope to kind of help you see what's behind the curtain and give you just a quick snapshot of what it is that we do with these interventions to enhance your understanding of them. So we'll start with the relaxation training. So to understand what we do here, it taps back to what's going on within the body with sensation perception. So basically, our brains are always on. The brain is always processing information around us. One of the things that the brain is responsible for is detecting the presence of threats or stresses in the environment. Whenever the brain detects the presence of a threat or a stress, it activates our sympathetic nervous system. When the sympathetic nervous system gets activated, there's a whole host of changes that happen in the body, all the stuff that's listed on the screen here. Heart rate increases, blood pressure increases, blood vessels constrict, muscle tension increases, digestive processes slow down, breathing patterns change, cortisol gets released in the body. All this happens instantly. We don't do anything to make it happen. It's all regulated by the brain as it detects the presence of a threat or stress. As the brain detects that a threat or stress is no longer present, it activates a parasympathetic nervous system, which accomplishes everything on the next slide here, which basically calms the heart rate, allows blood vessels to expand again, muscle tension reduces, and the body basically returns back to its previous baseline. So if we could go on to that next slide, please. So this also happens automatically as the brain detects that a stress or threat is no longer present. Now, all of you have felt this before. Think about if you're driving your car in traffic and all of a sudden somebody cuts you off. Immediately you tighten your grip on the wheel, you sit up straight, you hold your breath, you feel your heart beating a million miles a minute. This is a sympathetic nervous system activating in the face of stress. But as you realize you're a safe distance from that car in front of you, eventually the body calms back down, which is a parasympathetic returning you back to normal. So all of you obviously remember this from high school biology as being called the fight or flight response in our bodies. And everybody has it. This is just a part of our regular wiring. But what they don't talk about when they teach us about this fight or flight response is that this type of response happens in the face of any stress. To the brain, stress is something binary, meaning something is either stressful or it's not stressful. And anytime the brain identifies something as being stressful, it's going to trigger some of the sympathetic nervous system activation. Now, the magnitude of the activation does vary depending on the nature of the stress, but we get some degree of sympathetic nervous system activation in the face of any type of stress. Now, this is important in the context of pain because several aspects of that nervous system activation, including tightening the muscles, constriction of the vessels, can exacerbate pain. Now, think about if a person's got chronic low back pain. If the muscles in that body are tighter than they need to be, then it makes sense that the pain that they have in that region is going to be exacerbated as they have some of this sympathetic hyperarousal. So if we go on to the next slide. So with this, pain itself is a physical stressor. So the physical experience of pain is going to cause activation of the body's nervous system. Well, that sympathetic activation is going to turn around and feed into the pain, and it creates a vicious cycle where the pain essentially feeds on itself. But this is just the physical experience of pain. We know that when patients experience pain, they have emotions that go with it as well. Next slide, please. Patients can have anxiety, anger, guilt, sadness. Each of these emotions are also stressors, so they also activate the body's nervous system and become additional links in the pain. So regardless of what your surgical intervention is or your procedural intervention is, all of this hyperarousal of the body's nervous system can create changes that exacerbate the physical pain that a person is experiencing. So in relaxation training, what we do is we help patients learn how to quiet the sympathetic nervous system reactivity. We do this in a variety of ways. We can teach patients different types of breathing exercises. We can teach them different types of meditative practices. But there's more to it than just, oh, go sit in a corner and breathe, or oh, go count to 10. But it involves quieting the mind, paying attention to what people are focusing on, and really targeting the sympathetic parasympathetic axis. So in a nutshell, that's basically what we're doing in relaxation training, is breaking this left-hand side of this diagram here. Now, the other thing I wanted to talk to you about today is the role of cognitive behavioral interventions. You can go on to the next slide. So as human beings, we act as if we're stimulus response creatures. Something happens and we have some sort of response to that. And as human beings, if somebody asks us why are we behaving the way we behave, or why are we feeling what we feel, we attribute it to a specific situation. But the reality is it's not the situation that causes us to feel what we feel or act the way we act or have the physiologic responses we do, but rather it's the interpretation. Next slide, please. And the crux of cognitive behavioral theory says it's not the situation that determines things, but rather how we process it. And there's a lot of power in this because we can't always control the situation that we find ourselves in, such as pain, but we can change how we interpret that to influence what our physical, emotional, behavioral outcomes are. And physical outcomes include some of that sympathetic nervous system reactivity that can turn around and drive up physical pain. So next slide, please. So our thought processes, or the way that we interpret things, are rooted in our early life experiences. The way that we process ourselves, our role in the world around us, as well as the world around us, is all shaped by our early life experiences. And it continues to get modified or reinforced over the course of time through the experiences that we have, through the people around us. And these things can be very rigid. It can be very difficult to change our thought processes because, for one thing, we're oftentimes not even aware of how we're processing information. It typically occurs in our subconscious. And then once we become aware of our thought processes, even when we become aware of maladaptive thoughts, that by itself isn't enough to change fundamentally how we think about something. Because again, the thought processes are very deeply rooted. Just because we have an awareness of them doesn't mean that we've necessarily changed, but that's how we continue to process things. Next slide, please. An example of a maladaptive thought process that many of you have heard of that's been very rampant in the literature over the years is catastrophization. And catastrophization is essentially an exaggerated perception of a situation being worse than it actually is. There are three components to catastrophization: magnification, rumination, and helplessness. And I'm not going to go into detail into what those are just in the interest of time. But if we can go on to the next slide. What I will tell you is that their catastrophization is strongly associated with poor treatment outcomes. We know that catastrophization is associated with the maintenance of affective distress, depression, anxiety. People oftentimes adapt fear avoidance as a means of coping with catastrophization. They avoid activity out of fear that activity is going to cause more pain. And so they avoid activity, which actually leads to a worsening of pain over time. It leads to maintenance of symptoms, and it can lead to chronic disability. We actually know that people that have tendencies toward catastrophization are more likely to go on long-term disability than people who aren't. And all of this can prolong the duration of pain within the post-operative state. So in cognitive behavioral interventions, what we do is we target the catastrophic thoughts that people have to try to help them achieve healthier outcomes, which in this case would be a reduction of pain in that post-op period. So if we go on to the next slide, please. So there's a strong evidence base for the role of psychological interventions in the perioperative space. There's been moderate quality evidence for cognitive behavioral therapies and relaxation training in reducing persistent post-surgical pain. Go ahead, go on to the next slide, please. And so in summation, psychological factors can influence post-surgical pain and treatment outcomes. And perioperative psychological interventions can successfully address some of these variables, but they tend to work best when they're done in conjunction with other treatment interventions. So psychological treatment shouldn't be a standalone intervention, but it should be done in a multidisciplinary format in conjunction with things such as what we've heard Drs. Ha and Carroll talk about, whether it be opioid or non-opioid therapies. And with that, we'll go ahead and pass it on to the last presenter for the evening, Dr. Furnish, who's at University of California, San Diego, who runs a pre-op pain clinic and is also the fellowship director. Dr. Furnish.
Thank you, Ravi. I'm going to talk to you a little bit about transitional pain medicine. I don't have anything relevant to disclose. Next slide. One, I hope you learn a little bit about what the nature of transitional pain medicine may be. We've already learned some about risks for acute, difficult to control pain after surgery, and we'll talk some about opioid weaning and pain management techniques after surgical discharge. Next slide. So what is transitional pain medicine? So this is really a continuum of integrated perioperative pain services, pre-op, inpatient, peri-op, pain management, and then post-op. There are a number of centers around the country that are doing some form of this, or at least some aspects of this. Most of the published literature around this has come out of Toronto General Hospital and Salt Lake City VA Medical Center. Next slide. So the goals of transitional pain medicine are at least four. So one, to reduce the transition of opioid naive patients to becoming chronic opioid users, to reduce the dose escalation that patients who are already chronically on opioids will experience after a surgical surgery, and to improve perioperative pain management, especially for patients who are high risk for difficult to control pain after surgery, and hopefully to reduce the incidence of developing chronic post-surgical pain. So the elements of a transitional pain service, as I mentioned, are threefold. There is a pre-op element, risk stratification, looking at patients who are high risk for a number of elements, especially difficult to control pain after surgery or persistent opioid use after surgery. Patient education and evaluation in the pre-op period, and then perioperative pain planning in advance before they get to the hospital. There's an inpatient component, which will be centered mostly about a robust acute pain service that's doing comprehensive inpatient pain management. And then also we'll talk a little bit about discharge planning. And then post-operatively, a dedicated follow-up clinic that is focused on weaning patients off of opioids after surgery, especially high-risk patients, and evaluating those patients and treating them for chronic post-surgical pain. Next slide. So as I mentioned in that pre-op phase, one of the things we need to consider is risk stratification. And Dr. Prasad has talked about this quite a bit, which was great, so I won't belabor the point, but there are a number of things that make people higher risk for difficult to control pain after surgery. Age, gender, smoking status, depression, anxiety symptoms, sleep difficulties, certainly the presence of significant amounts of pre-op pain and the pre-op opioid use are all going to be factors. Next slide. Another thing that we want to consider in terms of risk stratification are those patients who are going to be higher risk for persistently using opioids after surgery. There have been a number of groups looking at this. The group on the left is out of Calgary, Canada. This was a meta-analysis looking at risk factors for persistent use of opioids after surgery. And they found a number of potential factors, again, prior opioid use, psychiatric history, younger age, history of substance use, female gender, history of smoking, tobacco, and alcohol abuse. The graph on the right is actually out of the University of Michigan. This is Chad Brummett's group, looking at the percentage of patients who are opioid naive before surgery who are going to persistently use opioids, and they define that as filling opioids, I believe, 90 to 180 days after discharge from the hospital. And they were looking to see if there was a significant difference between patients who had quote unquote major surgery versus minor surgery. And they found that there wasn't actually that much difference. Major surgery patients had 6.5% of them were persistently using opioids after surgery versus those in the minor surgery group, it was 5.9%. Again, these were patients who were opioid naive before surgery. Other groups have found somewhat similar numbers for the opioid naive group. You're going to see much, much higher numbers, obviously, for patients who are opioid tolerant or chronically using opioids before surgery. Next slide. One other thing that we should be considering in terms of stratifying risk is the risk of opioid overdose after surgical discharge. Just like we see with chronic opioid users, the higher the dose, the higher the risk. So patients who are on no opioid or minimal amounts of opioid after discharge have relatively low risks of opioid overdose after discharged. Those that were on more than 100 milligrams of morphine equivalent had much higher risk. Next slide. Also, as I think both Dr. Prasad and Dr. Ha talked about, there's a risk of chronic post-surgical pain after any surgical procedure. There are a number of things that people have looked at in terms of risk factors for chronic post-surgical pain. Certainly having pain in the part of the body that is being operated on before surgery is one. Pain elsewhere in the body is also a risk factor. Patients with significant comorbid stress symptoms, symptoms of capacity overload, and the intensity of acute post-surgical pain are also correlated with developing chronic post-surgical pain. Next slide. So what is involved in a pre-op evaluation or a pre-op pain consultation? So First of all, we talked a little bit about deciding who gets these consultations. It may not be practical and it might be pretty expensive to literally run every patient who's going to have surgery through a pre-op pain clinic. But certainly some patients who we know to be higher risk for difficult to control pain after surgery or the development of chronic post-surgical pain or persistent opioid use may be people that we want to target. And so one of the biggest groups is going to be chronic opioid users before surgery, especially those that are on high-dose opioids. People who are on complex opioid regimens before surgery would also be good candidates. So buprenorphine or methadone. Patients with intrathecal pumps, patients with significant anxiety or catastrophizing, patients with a history of difficult to control postoperative pain. All those would benefit from advanced planning and discussion prior to surgery. So what happens in the actual visit or visits? Well, the first thing is really gathering a good history from the patient. What analgesic intolerances do they have? What is their opioid history? How are they actually using opioid medications that they're being prescribed right now, and how much are they really taking? Developing some risk stratification and looking at their opioid risk factors, and then doing some very comprehensive pain planning before they hit the operating room. Pain education and setting expectations should also be a part of these visits. Patients frequently come to the hospital thinking that they're going to have no pain after surgery. They think modern medicine is miraculous. And it's important for patients to have realistic expectations, and better to be setting those expectations before surgery than afterwards. A robust pre-op visit, especially for patients with significant anxiety and catastrophizing symptoms, would probably also involve some psychological screening and treatment. Some of the things that Dr. Prasad was talking about in terms of cognitive behavioral therapy would certainly be of value. Last question is, should we be weaning opioids before surgery? I think this is an open question. Next slide. So there certainly are people who have proposed weaning patients off of opioids before a surgery. And I certainly can't argue that that might be a very good idea, but when we look for solid evidence about whether or not this is clearly going to be beneficial, there are not a lot of studies yet. This is one study which was actually does suggest that there is some benefit to weaning patients off of opioids. So this was a study done in patients who were having total joint arthroplasties. It was a retrospective cohort study. They found 41 patients who weaned their opioids by at least 50% before surgery. They found a matched group that did not wean opioids before surgery, and another matched group that were opioid naive before surgery. What they found was that the patient group that weaned opioids had significantly better activity scores after surgery. So WOMAC, UCLA activity score, SF physical component, compared to the group of patients who did not wean opioids. And in fact, those functional outcomes scores for the patients that weaned looked very similar to the opioid naive group. Whether or not we can generalize this to much broader surgical populations and suggest that all patients should wean off of an opioid, I think is an open question still. In order to accomplish that, it really would probably take some close coordination with your surgeons, because ultimately you're going to end up delaying some surgeries in order to slowly wean people either off or significantly lower doses on opioids. Next slide. So what about the inpatient portion of this? So if you've got a robust pre-op clinic, you're going to want to have them coordinating closely with your acute pain service. And a robust acute pain service is really the key to the inpatient portion of this. Dr. Carroll and Dr. Ha talked quite a bit about the perioperative management of opioids and non-opioids, and I'm not going to belabor that point, but you certainly are going to want a team that will take full responsibility for managing all aspects of the pain experience while they're an inpatient. So utilizing multimodal analgesia, utilizing regional neuraxial techniques, helping transition from IV to oral opioids in preparation for discharge. One thing that might not be a part of every acute pain service is some robust discharge planning for these patients. So how much opioid should we send each patient home on? Giving patients good weaning instructions, telling them how to use scheduled opioids and non-opioids as they go home from surgery, and identifying patients who may be high risk who would benefit from close follow-up from a discharge transitional pain weaning clinic. Next slide. So one aspect of that discharge planning is deciding how much are we going to send somebody home with. There are a number of groups that have started looking at how much opioid most patients use after basic surgeries. So the table on the left is from the University of Michigan, Michigan Open Group, looking at a variety of relatively basic surgeries, lap chole, lap appy, thyroidectomies, et cetera. And they looked at how many opioids these patients actually took in the days and weeks immediately after surgery. And then they set a threshold of the 75th percentile patient. So 75% of patients will use this many opioids or fewer. And so for an example, on the top line is laparoscopic cholecystectomy. They said 75% of patients will use 10 tablets or fewer of 5 milligram oxycodone, or 15 tablets or fewer of 5 milligram hydrocodone. There is at least one nonprofit hospital rating organization that rates hospitals on safety metrics that is proposing that all hospitals that they are rating will have to start using data like this when they're discharging patients from the hospital. So if we're not doing this currently, we may be pushed to be doing it in the near future. A slightly different way of doing this or deciding how much opioid to send somebody home with is represented on the table on the right. So this was a study that was done out of Stanford and the VA Palo Alto. This was in, I believe, total hip arthroscopies. They looked at how much opioid a patient was using in the 24 hours prior to being discharged. And then they developed essentially a sliding scale taper and determination of how many tablets to give them. So for instance, on the top line, if somebody only used 10 milligrams of oxycodone in the 24 hours prior to discharge, they gave them a taper of 1 to 2 days and sent them home with 4 tablets. If they used 60 milligrams of oxycodone in the 24 hours before surgery or before discharge, they were tapered over 11 to 12 days and they got 84 tablets. So this is a much more fluid way of looking at this compared to the tables on the left, but both may be something that we could be considering using more of in the future. Next slide. So we're now in that third phase after discharge. A post-op dedicated weaning clinic can serve really 2 major purposes. One, helping patients, especially patients who are high risk, to slowly wean off of opioids and encouraging them along the way. And 2, keeping an eye out and then potentially treating any chronic post-surgical pain that may develop. That post-op treatment plan is going to involve an opioid agreement, setting expectations, evaluating for opioid abuse, and then managing that wean. A really robust clinic probably is going to need to have psychological therapy as a part of it, whether that be cognitive behavioral therapy or acceptance and commitment therapy, be referring patients for physical therapy, potentially acupuncture, maximizing the use of non-opioid analgesics, and then especially in patients who appear to be developing chronic post-surgical pain, even considering interventional treatments. Next slide. So we talk a lot in chronic pain about the risk of patients being on opioids or being started on opioids. What we may not talk as much about are the risks of taking patients off of opioids. This was a study done in Vermont where they looked at patients who were discontinued from relatively high doses of opioids, at least 120 milligrams oral morphine equivalent. What they found was at least half of the patients that they looked at, this is a retrospective study, had no taper at all. They were just discontinued. 49% of the patients had some sort of opioid-related adverse event. So emergency room visits, hospital admissions for overdoses, opioid-related adverse events, or substance use disorder. Only 5% of the patients were tapered for longer than 90 days. What they found was that for each additional week of tapering, it reduced the risk of one of these hospital admissions for opioid-related adverse events by 7%. So the longer the taper, the lower the risk. Next slide. In a similar vein, this was a study in a VA population looking at all VA patients who were discontinued on opioids in a particular year. And what they found, they were looking primarily at how much opioid the patient was on prior to being tapered or discontinued. And they found, not unsurprisingly, that patients who were on much higher doses of opioids had much greater risk of either overdose or suicide after being discontinued or tapered off of opioids. So longer taper, lower risk, higher opioid dose before taper, higher risk. Next slide. So how do we go about tapering people? So the CDC has published guidelines recommending a 10% taper per week to start with, and then potentially adjusting that to 10% per month for patients who are on high dose of opioids for long periods of time. We should be watching for signs and symptoms of depression and anxiety, referring to treatment for these symptoms whenever we see them, supporting and encouraging patients along the way, and then adjusting the dose and the rate of taper as necessary. The CDC recommends that if you run into issues of withdrawal symptoms, that you try not to go backwards on the taper, but simply stop or slow the taper in order to allow patients to adjust. There was a study done at Stanford recently where they created something that they called the patient-centered opioid tapering regimen. So in this study, they did a 5% taper every 2 weeks for the first month, and then they did up to 10% every 1 to 2 weeks thereafter. And then they tailored the taper to patient response. Next slide. So some of the things that the Stanford group tapering regimen found, that there were a few things that were positively correlated with a successful taper, notably baseline cannabis use. Negatively correlated with a successful taper was depression, and things that weren't associated with a positive positive taper were the age of the patient, how much opioid they were on, or the pain intensity before the taper. What they did find that was interesting was that pain intensity and pain interference didn't increase while they were tapering or after tapering. So patients who were having lower and lower doses of opioids did not necessarily see increased pain scores. And this is a very important thing to point out to patients. The data suggests that merely tapering opioids, especially if we go slow enough and really support the patient along the way, does not necessarily increase their pain scores. Next slide. So this is the scatter plot from that study, showing that the vast majority of patients saw no change in pain score as the opioid was tapered. Those that did see a change in their pain score as the opioid was tapered, the majority of those actually saw a decrease in pain. There were a small number of patients who saw an increase in pain with opioid tapering. Next slide. So finally, just a few tips around this post-op opioid tapering. I think it's important to set goals with patients up front. Is our goal to get them back to where their baseline opioid use was before surgery? Is our goal to get them off opioids? Are we trying to do this in a relatively short period of time, or are we willing to do this over a very long period of time? I generally start with tapering sustained release opioids first, even if you have to slightly increase immediate release opioids. Our goal is really to consistently move the patient towards a lower total or oral morphine equivalent over time. We should always be supporting patients along the way. It's important for patients to understand that this is hard and we're not going to pull the rug out from under them. When we need to, adjust the frequency of the taper, slow it down, stop it temporarily. How fast we taper is really going to depend on what the dose was before we started tapering, and how long we would expect surgery pain to take to resolve for any particular surgery. And then pause the taper whenever necessary. And I think I'm going to stop right here.
Okay, well, thank you very much, Dr. Furnish, for finishing up there. First off, I want to ask our faculty all to come back on and bring their videos on so we can do some questions here at the end. I want to thank everyone for doing actually a phenomenal job. I think we now have a truly better understanding of the risk involved with our patients for pain management, and having an idea of putting in place protocols and mitigation plans to minimize their risk of chronic pain, as well as minimize their use of opioids. And I think we've learned from these great presentations that it's important to understand the options that we have. We're a little bit over on time, but I do want to make sure I try to respect a lot of the questions that came through during the talk. So we're going to try to do a little bit of rapid fire. But I think some of these first few questions that came across, I think hit home. As somebody like myself who's dual trained in complex spine as well as functional neurosurgery, I see both sides of the equation. I see the spine procedures that can lead to chronic pain and opioid use, as well as then treating those patients with neuromodulation and trying to get them off opioids. So this first question is going to go to Dr. Ha. I guess specifically, how do you address like high opioid users coming into the surgery?
Yeah, I think we prefer, so we have a pathway where patients get referred prior to their operation. So ideally, if it's an elective surgery, they will have come to see us at least one time so that we have a chance to, if they're not already, start the multimodals, whether it's gabapentin, NSAIDs, Tylenol, have the expectation, the counseling of how these medications are going to continue on as long as their opioid doses increase, but also to reassure them that it's a partnership. We're not going to be just taking away your opioids. We're not going to make it difficult. We're here to help you. But in that framework, also say we're typically brought on board for 2 to 3 months, which is usually more than enough time to get you at least back to your baseline opioid dose or even lower. So I like to leave things open-ended because when there is a threat that the medication might be taken away, then there seems to be a focus on that. So definitely if we have time, I would say that there are drawbacks to preoperative opioid weaning because we definitely don't want to put somebody into opioid-induced withdrawal hyperalgesia as they're going into their operation. So it really depends on how much time we have to work with them, and also coordinating with whomever is prescribing post-op. If it's us, that's great, or with the PCP to organize the plan.
I think that's a great answer, and actually it kind of leads into one of the other questions we got, which I think I'll gear towards you, Dr. Furnish. It talks about not being able to have a lot of time with these patients preoperatively, running a busy practice. So what kind of steps do you recommend for physicians to try to reduce the risk when they may not have access to a transition plan or a practice that can help them perioperatively like this?
I think patients get so much out of at least having a discussion about the plan going into surgery. And we don't actually have to take a ton of time to do that. I know surgeons almost never have time to do this. And that's not a knock on surgeons. It's not really their area of expertise. And so even a simple discussion about, all right, well, this is what's going to happen. We're going to do this for you in the pre-op area. We're going to ask our anesthesia folks to do this. Someone will see you post-operatively and put you on these medications, and then they will transition you from IV medications to oral, and then you'll get sent home on these other medications. and there will be a plan for how to follow up. And simply having that discussion, especially for patients who are exceptionally anxious, I think has a huge beneficial effect.
Phenomenal. I think that's great. I'm actually going to get Dr. Odestad and Dr. Rizzoli in on our questions here. And one of these questions was, how do you decide on starting with using opioids or trying to do non-opioid therapies in the post-operative period? We'll start with Dr. Odestad. What would you say?
As Dr. Carroll mentioned, we do have these non-opioids that seem to work fairly well, especially if we start them early. In general, we will go that route first, and only if we can't manage the pain with the non-opioid route will we routinely add the opioids.
Yeah, I think opioids is still main base of the pre-op pain management. We have some other adjuncts that we add them, and we try to basically taper it as soon as possible and just switch it from IV to PO, and then take the patients off as soon as possible. And still, unfortunately, is a main part of the best medications that we have, but they have some side effects that that we should think about that and try to basically start very low dose and taper it as soon as possible, and use other medications to reduce the amount of the opioids and lengths of opioid use by the patients.
Okay. Actually, Dr. Carroll, I even thought of a question listening to your presentation on the GABAPentinoids and also using ketamine. And I do a lot of outpatient surgery with spinal cord stimulators, and sometimes these patients are on opioids beforehand, sometimes they're not. I used to think it was useful that I would give limited supplies of opioids, 3 days post-operative, so I would make it almost a little more difficult for the patient to continue on opioids. But yet I still see that a lot of my patients will continue to call every 3 days or 5 days asking for more opioids. So putting together your presentation, like what would be your recommendation for like these type of procedures to reduce the chance that they're going to be using long-term opioids, or reduce the chance that they're going to have chronic pain?
So I think two separate issues there. One is about the long-term opioid use, and the other is reducing the likelihood of chronic post-surgical pain. And I think the third one, kind of implicit in what you're saying, is when you're dealing with patients with chronic pain and they're going to undergo a procedure, what special precautions might you take? And I think, you heard a lot of different strategies put forward by different people in this, and all of them potentially valuable. Addressing anxiety and expectations before surgery, having a talk with them, as Dr. Ha talked about what would their motivations be for coming off of opioids after surgery, the adjuncts that were talked about in my talk, which frankly often involve a discussion of somebody like you as a surgeon with your anesthesiologist. Hey, listen, talking to your anesthesiologist, I've seen some data that suggests that if we give perioperative gabapentin starting before incision and continuing through the surgery, that the likelihood of having pain 3 months out and 6 months out is substantially less. I understand that may result, especially as you're getting used to doing this, that may result in a patient taking a little longer to wake up, or spending 15 to 30 minutes extra in the recovery room. These are metrics that surgeons with a busy schedule, doing multiple outpatient procedures a day, are really sensitive to, and your anesthesiologist picks up on that, and they're trying to please you. And so hearing from you, hey, listen, on this particular patient, I'm not so pressed for time as I am interested in making sure that this patient isn't in my office 6 months from now talking about how their pain's worse after their procedure. And so who that is. That's, your patient who has CRPS in their upper extremity, who has gotten worse with everything that has been done to them, and you're being asked to put in a paddle lead in the cervical spine for a spinal cord stimulator, you know that that patient's at risk of being miserable afterwards, and for that increased pain to last a long time. And so telling your surgeon, hey, listen, or telling your anesthesiologist, you know, to me, it's worth it for you to take a little extra time to do some of these things, even though they may result in the patient being in the recovery room longer or waking up a little more slowly. And so I think it's a synthesis. What you've talked about, these complicated patients, is a synthesis of all the different talks you heard here today.
Wonderful. All right, well, there's two more questions I want to directly get to, and then I'm going to do like a rapid fire of 30 seconds for each one on the panel just to give some tidbit of advice. But this one question is for you, Dr. Ha. It says, would you continue buprenorphine and layer opioids during and post the procedure on top of it?
Yeah, so I can't point to like big randomized controlled trials, but there's plenty of like case series and observational reports of the protocols. And like I was saying earlier, if someone's on high dose, so like 24 milligrams sublingual, you want to bring that dose down as much as you can if you've got the leeway before they go into operation. Ideally like 16 milligrams total or less, like 8 to 16 range. And it's still possible to have even a moderate size operation, continue the buprenorphine and, you know, layer the PCA on top of it and somehow able to get adequate analgesia. And again, it's just weighing the risk and benefits with the, you know, from speaking with the addiction medicine hat on, we don't want people to leave the hospital and then now, you know, in terms of harm, are relapsing and heaven forbid having an overdose. So I think that there's, I'm leaning towards the camp of keep them on the buprenorphine if you can. The data is not 100% there yet, but hopefully we'll start to see that trickling in the next year or two, hopefully.
Yeah, wonderful. And I'm actually starting to see a lot more patients on that too in the preoperative period. And this is actually great for even me to see because it gives me a better plan on how to manage it. Dr. Prasad, there are several questions for you that I'm going to try to put into a summary. It seems like the idea of pain catastrophizing is a pretty hot topic here. So to kind of put these questions together, one is, you know, we get neuropsychological evaluations on a lot of patients before surgery. Is there certain screening tools you recommend? And then the other one is, how do you reduce catastrophizing?
So one of the tools that's out there that's most commonly used is the pain catastrophizing scale. And so it's a free public domain measure that's relatively quick for patients to respond to and relatively quick to score. And it provides information on those three different domains of catastrophizing that we talked about, the helplessness, the magnification, and the rumination. So that would be a good, quick, easy tool to use to gauge catastrophization. And generally speaking, any score that's a 30 or higher is what we consider something that's a high likelihood of catastrophization. In terms of what do we do to address catastrophization, the second part of your question, the primary thing there would be the cognitive behavioral therapies. You know, things like relaxation training, which is part of what I had talked about, that may help quiet some of the physiologic reactivity that comes with catastrophization, but it fundamentally doesn't change that thought process that drives the negative outcomes that we see. And so the most effective treatment for catastrophization is the cognitive behavioral therapy, which is targeting the maladaptive thoughts that make the person say, when you ask them on a scale of 1 to 10, what's your pain? Well, it's a 35, doctor. And so the cognitive behavioral therapy will be able to help address that.
Wonderful, wonderful. Okay, so in the interest of time, we're going to do just a rapid fire. Everyone gets no more than 30 seconds. We'll start with you, Dr. Ha. Just everyone gives a little tidbit now at the end.
Okay, a little bit of advice and encouragement goes a long way. Generally, keep it positive. Let patients know they're going to be able to get off of their opioids, and that's pretty much my spiel.
Okay, good. Dr. Otterstad.
Yeah, I would say earlier is better. If you identify these challenging patients a month before surgery, send them to the pre-op clinic so we can optimize it both verbally as well as medically. If identified in the pre-op area or even in a pre-anesthesia clinic, we can make interventions there. If identified in the hospital, get the acute pain consult in earlier. In general, the earlier we intervene, the better outcomes we have 6 months down the road.
I think that's great advice, and I think, you know, most surgeons are booking out at least a month, so they could do some type of planning like that. Dr. Carroll.
study after study shows that something like 10% of people wind up with chronic pain after surgery, and you have to have a plan to address that. When I get any surgery, it will be with perioperative gabapentin, asking my anesthesiologist to give me ketamine, and asking for that area to be made numb through regional anesthesia. And we should extend the same to our patients.
Great. That's the trifecta of what you presented today. Dr. Rasooli, you're on mute.
Okay, sorry. I want to emphasize on the point that less touched during these discussions is role of the surgeons and also role of the primary care physicians to identify those patients that basically most of those patients after discharge from hospital having pain and goes back to their surgeons or PCPs and complaining pain. I would say that it's very important for the role of the surgeons and PCPs to recognize those patients, identify those patients, and refer them to the pain specialist for the appropriate management.
Absolutely. Dr. Furnish?
So I would say that if anyone that wants to start the process of creating a transitional pain service, probably the simplest first step would be develop a strong working relationship between outpatient chronic pain folks who can do a pre-op assessments and an acute pain service, and really work on developing that collaboration.
Wonderful. And we'll end with you, Dr. Prasad.
I would say that not to forget that the most useful predictors of poor outcomes have been found to be a lot of the different psychological variables. So don't forget to look at some of these different psychological variables and try to employ as much of a multidisciplinary approach to managing the pain as possible.
Wonderful. All right, I want to thank our amazing faculty for such a great presentation, which I think I've even learned a lot listening to it. So I know it must be very enlightening for the people who were listening. And I'm sorry we couldn't get to all the questions, but we will try to, if we can, maybe email you afterward. So here's the web address so that you can obtain CME for tonight. And once again, I just want to thank everyone, and everyone have a good evening.
Thank you.